That's an interesting point, that there seem to be some differences in the clinical behavior based on the site of origin between, say, small bowel carcinoids and lung carcinoids. We also, though, very often pay attention to the cells, to the histologic characteristics. And maybe, Dr. Kunz, you can sort of tell us a little bit about what are the key characteristics when you're looking at the pathology report that might tell you if this tumor is going to be more aggressive or going to be more slow growing.
Sure, and I think this gets a little bit to what Rod was saying earlier, that the terminology has really just evolved over time. It's very inconsistent. The terminology is very heterogeneous, so even just the histologic descriptions of the tumors can be from neuroendocrine carcinoma to neuroendocrine neoplasm to neuroendocrine tumor. So histologic descriptions are quite varied depending on how they're reported and which institution they're coming from. I think that in an effort to try to make this a little bit more consistent, some guidelines have come out over years, including ENETS, the WHO, and recently David Klimstra from Memorial Sloan Kettering came out with some guidelines in 2010 reporting on, or creating guidelines around reporting for pathology, and that included variables that really needed to be part of these pathology reports, including Ki-67, mitotic index, grade, certain features of the tumor itself. And I think that the Ki-67 and mitotic index cutoffs currently for Ki-67 are less than 2 for the well-differentiated or low-grade tumors, 3 to 20 for the intermediate grade, and greater than 20 for the higher grade tumors. So the mitotic index cutoffs are slightly different. So the low-grade tumors are less than 2, intermediate greater than 2, up until 20, and then the high grade are greater than 20. And I think these are somewhat arbitrary, but really meant to help guide treatment, with where we really lump the low and intermediate grade tumors into a category and treat them differently than we would the higher grade tumors that typically are treated more like small cell lung cancers. I think what's interesting is I suspect that these cutoffs may actually evolve and change over time as we're learning more about the subtypes of these cancers. I'd love comments on that, because I think that we're learning that maybe some of the Ki-67 greater than 20s may actually respond differently to chemotherapies.
So what you're telling us here is that there are maybe two really key components to looking at the histology. One is the mitotic count, and the other is the Ki-67. And that they can help tell us if this is a lower grade, more indolent tumor, or perhaps a more aggressive form of neuroendocrine cancer. So James, if we sort of take those histologic characterizations, in your mind, how do those affect the way you might treat a patient? What clinical implications does it have?
Well, absolutely. I think that's a very good question. Well, I think these, I would say, histologic classifications and so forth can have several roles in how we manage patients. One is their prognostic effect. The other is really talking about the predictive effect in terms of how influence, in terms of what we do with the patient in terms of therapy. In terms of prognosis, in terms of terminology, you want to think about whether these tumors potentially could be malignant, or are they, in some cases, benign? Well, clearly for those who are intermediate or high grade, we clearly think they're all malignant, regardless of anything else. There's really in the low grade tumors, there's a question about what are the criteria under which these tumors could be benign. It is clear from autopsy series that there are probably only a small percentage of these tumors actually I would say, take the patient's life or behave in a very aggressive way. So there's a large percentage of tumors that are silent. At the current time, I think probably the best or the most frequently used cutoff is tumor size for these small tumors. For example, small insulinomas less than a centimeter in size, or small appendiceal carcinoma tumors less than a centimeter in size. And if they're low grade, they're generally considered to be benign in the way they operate. And if they have higher Ki-67, higher grade, or larger size, they're usually thought to have malignant potential. I think the biggest one that in terms of how influence we manage these patients, really the transition between grade 2 and grade 3 tumors, the intermediate to high grade area. Because there, I think the grading does have predictive potential in terms of telling us which patient should receive platinum-based chemotherapy, especially in the setting of more advanced disease, in which patients are more managed like a typical carcinoid or pancreatic neuroendocrine tumor.
You brought up an interesting issue here about the, defining benign or malignant tumors. So let me turn to Rod. From a surgical standpoint, do you think there's such a thing as a benign neuroendocrine tumor that you just leave there?
Certainly. These things are encountered in the fundus of the stomach very frequently. They're type 1 gastric carcinoids, and the only way they're going to kill you is if they convince you to cross the freeway at night wearing black clothes with a blindfold on. And the same thing with rectal tumors that are small and found on routine sigmoidoscopy and colonoscopy. And as more of that is being done, they're being encountered very, very frequently. Elsewhere in the GI tract, the tumors behave dramatically different with sometimes just a movement of a few centimeters. So in the small bowel, I don't view any of the tumors there as being benign. I see patients that have widespread liver metastases, very large mesenteric nodal masses at the root of the mesentery. And when I find the primary tumor that started all that, it is still only a few millimeters in size. So therefore, when we find a small bowel tumor by some other route in the small intestine, I can't by any imagination say that I think that that doesn't have malignant potential, because so many small tumors have had widespread metastatic disease at diagnosis. And then you move 2 more centimeters in the appendix, and they behave benignly again.
So clearly some differences there. And then the other point I think that James brought up was the difference in how we treat the high-grade tumors and the low-grade tumors when we think about chemotherapy. Pam, do you agree with that? Do you think they're different categories here? Are they different diseases in some ways?
I mean, I think given what we currently know, I think that they are, and I think traditionally we treat the higher grade or poorly differentiated tumors with cytotoxic chemotherapy. I think that the way most of the current clinical trials were done, certainly looking at the more well-differentiated tumors using some of the targeted agents, I think that I don't in practice use targeted agents to treat the poorly differentiated tumors. And if I can make just one comment about something that Rod said, I think that in terms of this question, are there benign tumors, benign neuroendocrine tumors? I think that, for a long time at many institutions, cancer registrars have been coding neuroendocrine tumors, all of them as benign, which actually for those of us who do any database research or even for the SEER database is actually really problematic in terms of looking at the natural history of these tumors.
You raise an interesting point. I think it's maybe something that we do need to be careful about, because historically, many of these tumors were considered benign or so indolent that you just didn't have to worry about them. And James, I think you've even done some work looking at databases that tells us pretty clearly that at least some of these tumors are not nearly as indolent and as benign as we might think.
Yeah, I think absolutely. I think Rob brought up a really good point, because these tumors are different at different primary sites. Even a tiny small bowel carcinoid tumor can have a great deal of malignant potential and can spread, whereas in the appendix and rectum they're more benign. And complicating all this is, our existing data based on tumor registry really only include tumors where the tumor registrar considered they're malignant. So although from surgical experience we know that appendiceal carcinoid is probably one of the more common carcinoid tumors, they actually represent a small portion of the large tumor registry. Same thing, if you look at the surgical series, small insulinoma is probably the most common pancreatic neuroendocrine tumor, but then you look in the tumor registry, they're not there, because probably there are some underrepresentation just based on the registry data.
So before we leave the topic of histology, I want to touch on one other issue. That is that there are some very unusual types of neuroendocrine tumors that are reported out as adenocarcinoids, mixed adenocarcinoma carcinoids, goblet cell carcinoids. Rod, can you tell us what these things are and how should we treat them?
Well, I think the hope, these are often dual component pathology reports with an ominous component like the adenocarcinoma, the goblet cell, and then there's the neuroendocrine features. And I think what's hoped in that pathology report is that the neuroendocrine component conveys the rather indolent nature and good prognosis that we come to expect with some of the midgut carcinoids, where there can be prolonged survival even with metastatic disease. And I always interpret that to mean that, no, we just have neuroendocrine features, and it's going to be the other component, the goblet cell, the adenocarcinoma, that is going to drive the outcome and survival, and it should be treated that way rather than as a neuroendocrine tumor. And I'd be really interested in what you three medical oncologists say about that.
Yeah, I mean, I would agree with Rod that, I think these tumors, particularly the goblet cell carcinoids, actually tend to behave more aggressively and actually have a poor prognosis. The reverse can happen. I've seen a mixed adeno, poorly differentiated neuroendocrine tumor. So I would probably say that you treat what's the most aggressive component of that histology description.
So an adenocarcinoid of the appendix one might treat with a colon cancer type regimen, because that is probably what's going to be driving the outcome here.
Precisely.
Right, I agree.
All right.
There's some differences in terms of pattern metastasis too, because those tumors, unlike the well-differentiated neuroendocrine tumor, are far more likely to present with peritoneal metastasis than liver metastasis. And I agree, we treat the more aggressive component, but we really don't have any level 1 data about whether the standard colon regimens work as well as in colon cancer.
James, did you include those in your epidemiologic description when you looked at those tumors, and did you look at them separately?
We did. When we queried the SEER database, we did look at the mixed histology tumors, and they tend to have a kind of somewhat an intermediate course. They're clearly more aggressive than the standard well-differentiated tumors. But we have not yet been able to sort out whether they respond to the standard adenocarcinoma regimens yet.